speaker, Dr. Nicola Courage. She's consultant pediatrician in Edinburgh, director of education, Royal College of Physicians in Edinburgh, and editor of the Wilson medical textbook. She's going to talk about falls prevention in old age. Welcome, Dr. Nicola.
Thank you very much, and thank you very much to the organising committee for inviting me to give this talk. As populations age, falls become an increasingly common presentation. In Jordan at the moment, around 3.5% of the population is aged over 65, but the equivalent figure in the UK is 16.5%. So there's rarely an acute medical tape goes by where we won't admit a patient like this. This is Mrs. Knopf. She's aged 82. She's come into your acute medical unit from A&E. She can't walk after a fall. She has a past history of cataracts, depression, osteoarthritis and hypertension. And she's still living alone, but she's needing a bit of support to prepare her meals. So what goes through your mind? Well, perhaps the more ill-informed might consider this to be a social admission. The better informed, the first thing that crosses their mind is, could this lady have collapsed due to some form of acute illness? A further thought might be, could she have in fact had a syncopal episode of some sort? But in reality, the situation is often a great deal more complex, and many of these patients have multiple contributory comorbidities that put them at very high risk of falling. So what my talk is going to cover, try to answer a number of questions. First of all, why are falls important? Why are older people so prone to falling? Can falls risk be identified? Can falls be prevented? And finally, how do we actually apply this in day-to-day practice? So first of all, why are falls important? Well, they're certainly extremely common. Amongst people aged over 65, around a third will report that they've fallen in the past year, and that rate rises with age and with frailty or dependency, so that those living in care homes, around 60% will have fallen in the past year. And people that suffer from dementia, as you can see there, are at particularly high risk as well. The consequences of these falls are quite horrifying. Amongst those aged over 65 in the UK, falls result in 85% of the deaths due to accidents at home. They cause 1 million non-fatal accidents each year, and this puts a huge pressure on our emergency departments. Falls make up about 45% of the attendances there, and of these people, around 20% will need to be admitted to hospital, and this is often with the complications of a long line, hypothermia, hypostatic pneumonia, or dehydration. Around a quarter to just over half of falls result in some form of injury, and between 2 and 5% of people that fall will have a fracture as a result. Now, the cost to the NHS in the UK is huge. It's over £2 billion a year. I guess that would translate to about just under 3 billion JD. Don't be fooled, however, by this figure for fracture. That doesn't look too bad. You think, well, 2.5%, 2 to 5%, that doesn't sound too bad. But actually, it masks the fact that if you ask older women how they sustained their fracture, you can see most fractures are the result of a fall. Osteoporosis clearly compounds this problem. It becomes much more prevalent with age. Estimated annual incidence about 12 per 100,000 population. In the UK, we see over 300,000 osteoporotic fractures each year. And that the most serious of these is the hip fracture. And as you can see, this is a fracture really that affects the very old. Mean age of hip fracture patients being 81. And it's a very poor outcome. 30% will die within the next year. And of those that survive, half will be then partly dependent and 30% totally dependent. So we need to do something about this. So the first step is, well, why are old people so prone to falling? Well, you can measure balance using force platforms. And this is a rigid plate with a load cell at each corner. If you stand a subject on the plate, the load cell will read positively as the patient sways towards that load cell, but negatively as they sway away. So if you compute the data from all 4 load cells over a specified time, it will measure the movement of the patient's centre of gravity, or their sway path length, over that period. And as you can, and this wiggly line, if you like, represents just how much the patient swayed over, say, a minute. As you can see in the graph here, the sway path length, therefore that movement of centre of gravity, gradually increases even with healthy aging. So why should that happen? Well, we're spoiled for choice, really. There are all sorts of changes that occur to sensory input as we age. Our vision deteriorates, proprioception and vestibular function change, reaction times slow down, muscle activation and movement times increase, and muscle power and muscle strength gradually decline as you get older. Overall, it seems amazing that older people can balance at all given all those changes. But can we identify any particular of those changes that's most important? Well, it looks as though reaction time increases is the key factor. And this has been demonstrated in a very elegant experiment. Again, this used a force platform, but in this experiment there was also a visual surround, and you're seeing, if you like, a cross-section of that surround here. But if you can imagine, that came all the way around the patient. The other feature about the system used was that the visual surround could be programmed to sway with the patient. So as they sway forward, so did the screen in front of them. As they swayed back, so did the screen in front of them. Hence, the brain was given very conflicting information because vision was sending back messages to say, you're not moving, you're still quite still, whereas proprioceptive information from the ankles and feet was telling the brain, no, you are swaying. And somehow the brain had to resolve that conflict to keep the patient upright. I should add to that the support, the actual plate itself, could also be referenced to the sway of the patient, such that it would tip forward as the patient leant forward, and tip backwards as they leant backwards, thus again giving the brain very conflicting information as to what was actually going on. So the experiment performed compared 2 groups, healthy young people, healthy older people, and they used a number of different sensory conditions under which to test them. Oops, no. First of all, they just test them under normal conditions without any of the sway referencing I've described. They then blindfolded the patients. They then used the sway reference system just of the visual surround. They then gave them normal vision again, but sway reference the support. They then kept the sway referencing on support, but blindfolded the patient again. And finally, they sway referenced both the vision and the support, so utterly confusing information for the brain to have to resolve. The equilibrium quotient is just a measurement of balance, and as you can see, they also looked at the number of times patients actually fell over, subjects fell over during the experiment. I should add, it was all very safe, there was a harness, nobody actually had ethical approval all obtained. But what you can see from this is under normal conditions, the older people are only very marginally worse off than younger in terms of their balance. And even if you remove vision, or indeed sway reference vision, older people could maintain their balance still reasonably well compared to the younger group. It was only when you started producing sway reference support that things went horribly wrong for the older group, and much worse for the younger group. And as you can see, as you sway reference or remove the vision as well as the support, older people got into terrible trouble and began significantly losing their sense of balance altogether and falling. So what this tells us is that the older brain just cannot resolve complex sensory information quickly enough prevent falls. However, having said that, it's difficult to differentiate physiological changes in aging from subclinical disease. And neuroimaging studies have shown us that older people with poorer balance have more in the way of white matter lesions, larger ventricles, more in the way of sulcal whitening, and more ischemic infarction on MRI scanning, which suggests, in fact, that some of this imbalance we've been attributing to old age is, in fact, due to subclinical cerebrovascular disease. There's no doubt also that comorbidity is much more important in terms of falls risk than aging alone. And this study of British women aged between 65 and 80 demonstrates this. What it found was that the rate of falling per year rose dramatically with the number of chronic diseases present. So these included circulatory disease, depression, and arthritis. And even if you adjusted that for age, drugs taken, BMI, alcohol consumption, hemoglobin concentration, and so forth, you still find that those with no comorbidities reported a 10% rate of falls per year, while those with 5 comorbidities or more reported a 40% rate of falling each year. So can we identify those at risk of falling? Well, there have been numerous studies looking at this, and I'm going to just present a meta-analysis of these studies. And perhaps not surprisingly, the main risk factors are muscle weakness, history of falls, and gaze and balance deficits. But you'll see how far down the list age comes per se for putting people at risk of falls. The other things to note from this result is that whilst many of these risk factors cannot be modified, things like age and often cognitive impairment and arthritis are difficult to alter, there are, however, many other risk factors that can be modified. Muscle weakness and balance can certainly be improved even into advanced old age, which begins to give us some ideas as to how we might prevent people falling. The other factor that seems to increase risk is cardiovascular disease. It's certainly been shown that those with a lower standing blood pressure, intermittent claudication, or postprandial hypertension are at greater risk of falls. As I said at the start, there's quite an overlap with syncope, and in selected populations in whom falls couldn't be explained, very high rates of orthostatic hypotension, carotid sinus syndrome, and vasovagal syncope were identified. Often people think that the environment is very important to falls, but that's certainly the case in that about 30 to 50% of falls seem to be related to some form of environmental hazard. But in fact, environmental hazards don't identify those at risk, so they're not terribly helpful. So can we prevent falls? Well, there's now been, as you can see, literally hundreds of trials looking at this, and the latest Cochrane review of these trials found nearly 160 with over 79,000 participants. These were people all living in the community. And this review looked at 2 outcome measures: the rate of falling, that is the number of falls per individual a year, and also the risk of falling, which compared a control group with an intervention group. And they found 7 interventions that were effective. The most effective was exercise. And by this, I mean largely exercise to improve people's balance and strength. This could be delivered as a group or to individuals. It wasn't as effective in people with Parkinson's disease, severe visual impairment, or stroke. The other specific form of exercise that's proven very popular certainly in Europe and the States is Tai Chi, which is a martial art from the Far East, which involves slow rhythmic movements, which can improve balance. This certainly reduced the risk of falls, but not the rate. The other interventions that were effective were, first of all, home safety assessment and modification, assessment and multifactorial intervention. This is where, if you like, they took all 6 or 7 of the interventions and applied them to each individual as per the risk that was identified in them. The other interventions that are effective are looking at patients' medication. Firstly, the withdrawn any psychotropic medication, attempting to withdraw this is very effective, as you can see. The problem was in this single study that these results are derived from, they were very honest about it. They said all the subjects asked if they could go back on their sleeping pills at the end of the study. So it's not clear just how practical withdrawing them is. The second prescribing modification program was a very extensive program. This study was set in the States, and it involved giving the physicians involved financial incentives. And that's not likely to be applicable in other health services in the world. The fifth intervention that was effective was pacemaker insertion in those with carotid sinus syndrome. However, it has to be said that's a very rare cause of falls, and you have to screen an enormous number of patients to identify the few people that would benefit from this. Removing a patient's first cataract is, again, a very effective way of reducing falls. And a complicated podiatry intervention, which involved not just caring for people's feet, but also an exercise program for their ankles, was again effective. They also found some things that weren't effective. Vitamin D, first of all, didn't appear to be effective. There's much debate about this, in that there are many who feel that it may be effective in those who are actually vitamin D deficient in the first place, and that some of the trials that were performed here were perhaps inappropriate by just indiscriminately giving it to everyone over a specific age. Treatment of visual problems other than the first eye cataract surgery didn't seem to help. For instance, taking out a second cataract didn't add anything in terms of falls risk. Educating patients and cognitive behavioural therapy, again, were not effective. So, in the UK, the National Institute of Clinical Excellence is a UK government organisation that produces guidelines on various clinical conditions. And they produced their first guideline on falls assessment and prevention back in 2004, and that was updated again just last year. They identified 5 different priorities. First of all, case and risk identification, multifactorial risk assessment and intervention. They pointed out the need to encourage older people to participate because they're often reluctant to confess that they've fallen, and also the need to educate professionals that falls prevention is possible. So in terms of case and risk identification, it's very basic. The best way to identify someone at risk of falling is to establish if they've fallen already. If they have, you then want to go on and look at their gait and balance to assess whether it is indeed unsteady. There's many different measurement tools you can do that, but one of the most popular and simple in the UK is the Get Up and Go test, and that's exactly what it is. You simply ask the patient to stand up from a chair, watch them rise, walking, get them to turn around and go back to the chair. What you're observing for is if they appear unsteady at any point in that assessment, in which case they're going to need further assessment for falls risk factors and intervention. Now, the assessment that NICE suggests is a very comprehensive review of all the potential disabilities, diseases and drugs that might contribute to an individual's risk of falling. Now, that type of comprehensive assessment is routine practice for geriatricians such as myself, but much more of a challenge in the emergency department or the acute medicine unit. And that, I think, has presented one of the problems of delivering this guideline. In terms of intervention, NICE plumped for the multifactorial approach, that is, identifying each individual's risk and then addressing them specifically for that individual. But they pointed out that most successful programs included strength and balance training, a home hazard assessment and intervention, visual assessment, obviously particularly for cataracts and referral along, and medication review and modification or withdrawal of drugs that put the patient at risk. And I have to say it's been a significant challenge in the UK to put together the multidisciplinary teams that you need to deliver such complex group of interventions, including physiotherapy, occupational therapy, pharmacy, and a geriatrician. But in most parts of the UK there are falls prevention services now in place, and believe me, they're very busy. So how do we apply this in clinical practice? I'm going to go back to Mrs. Knopf that I spoke about at the beginning. And probably the best thing to do is simply to think of these three potential problems that may have underpinned her particular fall. And first of all, acute illness. Falls are a classic presentation of illness in old age, and perhaps the word fall is a misnomer, and the patient actually collapsed with this acute illness. The reduced reserves of balance I spoke about are going to increase this risk of collapse when people are ill. It's much more likely if the patient is also delirious. And you may ask, well, what acute illness are we talking about? And I would just say any. It could be sepsis, it could be a stroke, it could be heart failure. You have to do a comprehensive search to find out. Syncope is much less likely, but still possible. You're really looking for a clear history from the patient or a witness that there was loss of consciousness at the time of the fall. And it's worth bearing in mind that postural hypertension or vasovagal episodes are a much more common cause of syncope in this age group than arrhythmia or structural cardiac disease. I've just defined postural hypertension for you there, drop more than 20 millimeters in systolic or 10 in diastolic blood pressure. All these patients should have a 12-lead ECG, and if it does show any abnormality suspicious of an arrhythmia, it is going to be worth pursuing a 24-hour ambulatory ECG. But I would absolutely counsel you against doing indiscriminate 24-hour ambulatory ECGs in every old person that's fallen. This will be completely fruitless, and in fact, that's been demonstrated in that publication that I quoted there. So finally, treatable falls risk factors. And there's no doubt that many patients that fall because of an acute illness also have many risk factors that make them more prone to that. And it's all very well treating their acute illness, but if you don't address those falls risk factors at the time, they're going to represent with the same problem within the next year. So, in Mrs. Knopf, what do we know about her? Well, she's got cataracts. Do we need to refer her to get the first one out? She has depression. Is she on psychotropic medication for that that's putting her at higher risk? Could that be altered? Could the dose be reduced? Does she still need it? She's also got arthritis. Is this causing her gait and balance problems that we could improve with physiotherapy and better analgesia? And finally, she's got hypertension. So is she on drugs that could be causing postural hypertension that again, we could either stop or alter to reduce that risk? The other thing I'd like to draw you back to is this notion of osteoporosis, and the need to address that is just as important as addressing falls risk. And there's no doubt, as I say, as a comprehensive assessment, we would also always assess someone's cognitive function too. So management is fairly self-evident in that you're going to want to treat the acute illness, identify the conditions affecting balance, maximise their treatment, correct postural hypertension, rationalise the medication, check the vision, especially for cataracts, but ensure that these people are referred to physiotherapy, because balance and strength training is the most powerful tool we have for preventing falls, and also occupational therapy for the home hazard assessment. We would generally give people vitamin D and calcium replacement if they are housebound or living in a care home. And you could argue that everybody in Scotland has limited sun exposure, but as I say, we tend to restrict this to people who are getting no sun at all. There is good evidence from France that does reduce the risk of fracture. But clearly we have to assess osteoporosis a bit more thoroughly than that. And increasingly in the UK we're using the WHO FRAX tool as a much more effective way of assessing risk of fracture than a bone mineral density alone. Bone mineral density will make the diagnosis of osteoporosis, but it's not a good predictor of who's going to fracture. So with the FRAX tool you look at other risk factors as well, previous fracture being the strongest, but also glucocorticoid use, family history of fracture, whether the patient's a current smoker, what their alcohol intake is, and whether they have a history of rheumatoid arthritis. You can then add in the bone mineral density, And if you don't have access to DEXA scanning to measure that, you can also substitute the body mass index. And as you can see, this table is based on the British data, but you can also access from that website the data for the Jordanian population to measure risk in your own patients. But the greater number of risk factors you have, as I say, the greater your risk of fracturing over the next 10 years. And that would guide us in terms of who should receive specific drug therapy for osteoporosis. I've just put up this slide very briefly to give you an idea of how we would treat osteoporosis in the UK. I'm not going to talk about each drug individually, but just to highlight the need to treat osteoporosis alongside falls. So in summary, old people's balance is affected by physiological changes, but most falls are the result of comorbidity. Those at risk can easily be identified. Anyone who has fallen in the past year and is unsteady or slow on get-up-and-go testing. Falls prevention is effective in those living at home with an individualised, multifactorial, multidisciplinary approach. And osteoporosis risk must also be addressed if you're going to prevent falls injury. Thank you very much.
And she's going to discuss the dizziness in the old age. Dr. Milton.
Thank you once again. I don't think the microphone is working.
It's not working.
No.
It's not working. Please,
So my second talk is about dizziness, and in the words of a very distinguished British neurologist, W.B. Matthews, I think he summed it up very well, that there can be few physicians so dedicated to their art that they don't experience a slight decline in spirits on learning that their patients complain of dizziness. He's also a master of understatement. It is a really difficult diagnosis to sort out. Why is that? Well, I guess there are so many potential causes of dizziness that often you just feel like giving up before you start. I think acute dizziness is relatively straightforward. It can occur in the context of sudden hypotension, be it an MI, a GI bleed, or a big PE. It can also occur in hypoglycemic patients, usually in relation to antidiabetic therapy. In older people, it can occur in the context of a posterior circulation stroke. Occasionally, an attack of Meniere's disease may present this way, or very occasionally, at least in old age, vestibular neuritis is a more common problem in younger patients. The much harder problem I find is the chronic episodic dizziness that patients complain of, and that's what I'm going to concentrate on in this talk. The first difficulty you face is that dizziness is an extremely difficult sensation to put into specific words, certainly in English. If you stare at that screen for a moment and then try and put into words what it is you're feeling, it's not easy, is it? And the same applies to patients, certainly, as I say, who speak English. They come up with all of these rather vague and woolly terms that I must admit we would struggle to know exactly what it was they were trying to describe. The important thing to remember is the three main symptom domains that apply in dizziness: vertigo, lightheadedness, and unsteadiness. So if you are struggling to understand, or the patient is struggling to describe their symptom, it can be very helpful to ask them which of those terms best describes what they feel, because by identifying that symptom domain, you will immediately narrow down the potential underlying diagnoses. So for the rest of my talk, I'm I'm going to concentrate on those three symptom domains and take you through how best to assess them. So if we begin with vertigo, there are three main diagnoses that may be possible here. Obviously, some affect the peripheral vestibular system, some more located in the brain stem, so it's important to ask about hearing and neurological symptoms as well. The first condition, benign paroxysmal positional vertigo, possibly Meniere's disease, or finally a posterior fossa lesion. And older people in our country think largely a vascular disease in that situation, with space-occupying lesions and demyelination being much less common. So we're going to start with BPPV. This is a condition in which patients describe very brief episodes of vertigo when they change position, particularly lying in bed, turning over, getting into or getting out of bed. They're perfectly well between these very brief episodes. There's no effect on the hearing at all and no neurological symptoms. If it's left untreated, it will eventually resolve after several months, but may subsequently recur. So what causes that? Well, what happens in BPPV is that otoconia are shed from the surface of the utricular macula, and they settle into the endolymph of the semicircular canals and fall to the most dependent point within the posterior semicircular canal. It may happen for no reason, but you do see it after head trauma, occasionally after viral infections, and sometimes it's caused by ischemia. So what happens is, whenever the patient moves their head, these otoconia within the endolymph set up turbulence, if you like, and the patient experiences that as vertigo. The diagnosis is made clinically using the Hall pipe test. This is a very simple thing to do in an outpatient clinic. You ask the patient to sit on a couch and position them such that their head will hang over the end of the couch when they lie down. You then tell them that you're going to lower them down quite briskly, with their head turned towards the side where you're standing. You must explain to them to keep their eyes open, because the way you're going to make the diagnosis is to watch for nystagmus. So if the test is positive, there's usually a brief lag period where nothing happens, and usually the patient cries out and clutches you because they get appalling vertigo and they think they're going to fall off the couch. What you will see happening to their eyes is that they have very striking rotatory nystagmus. It looks as if the eye is actually rotating in the socket. That usually disappears after about a minute, as does the symptoms, and the patient recovers. But if you sit them back up again, you'll get another brief episode of nystagmus and vertigo. If you repeat the test again on the same side, however, both the symptoms and the nystagmus tend to fatigue. If you test the patient on the right and nothing happens, you then sit them back up and try on the left to see if it's the other inner ear that's affected. But I've taken great care to describe to you exactly what you'll see in BPPV, because you may also get a positive reaction with cerebellopontine angle lesions, but it's a different reaction. There's no lag period. The symptoms may be fairly mild or absent. The nystagmus is usually vertical rather than rotatory. It may change direction. And it tends to persist as long as you keep the patient in that position. If you repeat the Hall pipe test again, you find there's no fatiguing. They get exactly the same nystagmus and symptoms if they had any. And if you find a pattern like that, these patients are going to need neuroimaging, because that signals a cerebellopontine angle lesion rather than BPPV. So what about treatment for BPPV? Well, this is extremely satisfying. What you do, again, there and then in the clinic, is to perform an Epley maneuver. Now, this has been shown in systematic reviews to be extremely effective now. And the underpinning theory for an Epley maneuver is that you are draining the otoconia from the endolymph in the posterior semicircular canal into the endolymphatic sac. As I show you this, you'll think that this looks very unlikely, but it is remarkable how effective this maneuver is. The first step is to lie the patient again in a Hall pipe test on the side that was positive. but this time wait for at least a minute after their nystagmus and vertigo resolves. Then turn their head round to the other side without sitting them up between times. Wait for a minute for any nystagmus and vertigo to settle, then move on to the next position. This one's a little bit more of a challenge for the patient, in that you're going to ask them to lie on their side, but keep their head in the same relationship to their shoulder, so they end up looking at the floor, like this. Hold that again for a minute, and then the final manoeuvre, you ask the patient to swing their legs over the side of the couch and sit up with their head bent slightly forward, like this. You instruct the patient to try and keep their head upright over the next 24 to 48 hours, to try and sleep propped up as much as they can. Don't bend over to pick things up off the floor. And as I say, remarkably good response to this. Most patient symptoms are treated, resolved immediately. Meniere's disease, much less common to have its onset in old age. It would be more likely to come on in middle age, but it's associated with unilateral dilatation of the membranous labyrinth. Vertigo is quite different and associated with hearing loss, so quite unlike BPPV. Often the patients will also complain of tinnitus and a feeling of pressure within their ear. And the vertigo tends to be more persistent. It will last minutes or hours rather than seconds, sometimes even up to a whole day. And it's often associated with other symptoms like pallor, nausea, and vomiting. It will be very variable, however, in its severity. The diagnosis is made by audiometry, electronystagmography. Not nearly so much fun as doing a hot bite test. Treating it, well, the first step is to try and prevent attacks, and that is most effectively achieved by a low-salt diet, diuretics, and avoiding coffee. If the patient does have an acute episode, vestibular sedative such as sonarazine can be helpful. But occasionally you get patients with very refractory vertigo, which is quite disabling, and in those cases you have to resort to destroying the vestibular nerve, either with a neurectomy or intratympanic gentamicin. It's important to remember that brainstem disease, such as here this MRI of an acoustic neuroma, is extremely rare in patients presenting with dizziness alone. However, you should image those that clearly have other neurology or neurological signs, patients with high vascular risk factors, or one of the atypical Hall-Pike responses that I described. Okay, so let's move on now to lightheadedness. This is extremely common in old age. A number of potential causes. Anxiety is the most common cause in people under 65, but rarely the only cause in older people. Often you'll get hints like they'll describe perioral tingling or tingling in their fingertips. And you can sometimes reproduce it in the clinic by asking the patient to hyperventilate, as that's the most common mechanism for dizziness in this state. And you can demonstrate to the patient the connection between the two, and then teach them rebreathing and relaxation techniques. Cervical OA is worth thinking about in the patient who describes feeling very lightheaded when they look up or turn their head briskly. And again, you can reproduce their symptoms by getting them to show you the movement that brings on their symptoms. The one important thing to note though is that if syncope occurs on head turning, it could be carotid sinus syndrome, not cervical OA, so you'd have to go down a different path of investigation. Cervical OA would never cause syncope. However, it's extremely important in the lightheaded patients not to miss a cardiac diagnosis or a neurally mediated syndrome, because these are the ones that are associated with morbidity and mortality. So in terms of cardiac causes, obviously anything causing an outflow obstruction may cause lightheadedness on exertion. Sometimes that may culminate in syncope, so aortic stenosis and hypertrophic obstructive cardiomyopathy are really the lesions you're looking for, suggested obviously by systolic murmurs. Pulmonary embolism will obviously tend to occur more acutely and less likely in this chronic episodic dizziness that I'm describing. It's also important to remember that severe coronary artery disease can also cause simply dizziness on exertion, so the patient may need assessed for this too. As regards arrhythmias, well, almost any arrhythmia can result in dizziness, and The key here is that often symptoms will occur spontaneously rather than just on exertion. Clearly exertion may worsen them. So hints may come from the patient's ECG. They may have a sinus brady or an AV block on the branch block, significant axis deviation, or changes in the QTC that would give you a hint that an arrhythmia might be a problem and suggest that you should proceed to 24-hour ambulatory ECG. But obviously, almost any arrhythmia can result in lightheadedness. More commonly, a block or atrial disease, ventricular tachycardia is more commonly would cause syncope. The difficulty is capturing an episode of symptoms on a 24-hour tape, especially if the symptoms are infrequent and short-lived. Obviously, implantable recorders have been a major help in this regard, but there is another issue. As you can see, it is a big but. The ECG abnormalities are only important if they coincide with symptoms. You must remember that up to 15% of older people have asymptomatic arrhythmias. So unless you find the arrhythmia associated with a bout of symptoms, it may be completely irrelevant, and treating it is not going to improve the outcome for your patient. So what about the neurally mediated causes of dizziness? Well, the principal ones in old age are postural or orthostatic hypotension and vasovagal syndrome. I'm not going to talk at length about postprandial hypertension or situational symptoms, which are usually fairly obvious from the history. Carotid sinus syndrome tends to cause syncope rather than dizziness, so I don't usually consider that if the patient is simply dizzy. So postural hypotension, already said, defined by 20mm drop in systolic, 10mm drop in diastolic blood pressure within 3 minutes of standing. Prevalence increases with age, and it's associated with an increased risk of falls and stroke and an increase in mortality. The major contributors to it are apart from age, would be dehydration, medication, cardiac disease and anemia, and very occasionally you'll find people with specific syndromes causing the problem, such as multiple systems atrophy, Addison's disease, or they may have an autonomic neuropathy due to diabetes. But probably the most significant thing in older people are drugs. Older people commonly have comorbidity, multiple medications, and as you can see, a large number of these can cause postural hypertension. A quick way to remember them is anything with the prefix anti is probably going to be a problem. A few other significant ones, particularly alpha blockers in older men with prostatic problems, but benzodiazepines, opiates, alcohol also important. Probably the worst offenders, because they're so commonly used, are the antihypertensives. So how do you manage it? Well, first of all, self-evident. Review and stop any current medication if you can, or use an alternative. Patient education is really important. Persuading people to maintain a reasonable fluid intake between 1,500 and 2,000 mils a day. Older people have much less of a thirst drive and need to be encouraged. You can also teach them counter-pressure maneuvers to do before they stand up, such as fist or forearm clenching, gluteal clenching, or leg crossing, which can be very effective and indeed has been shown in randomized trials to be effective. Thromboembolic stockings are effective, but frankly most frail older people can't get them on, so they're not very practical. Increasing salt intake is completely counterintuitive in Scotland because everyone eats far too much salt already, so we don't tend to recommend this. Medication is difficult to use in older people. We've heard already from other talks about the problems of NSAIDs with adverse effects on the stomach and kidneys. Fludrocortisone can help by causing a degree of salt and water retention, but it's difficult to prevent that tipping patients into fluid overload. The other alternative is midodrine, which is an alpha agonist licensed for autonomic neuropathy and diabetes. Most older people cannot tolerate the adverse effects of that at all. So, as I say, it's usually about stopping drugs rather than starting drugs. Vasovagal syndrome, although everyone thinks of that as a cause of syncope, very commonly you just get pre-syncope and this horrible feeling of lightheadedness. And the triggers are very commonly prolonged standing, particularly in a hot atmosphere, even worse if the patient has a systemic illness. So very helpful to find out what the patient was doing at the time of their symptoms. It's often associated with nausea, sweating and pallor, quite unlike cardiac symptoms. And there are several drugs again which can increase susceptibility that are worth asking about. Now generally the diagnosis would easily be made from the history, and it's only if the cause is very uncertain that you would resort to tilt testing. This involves lying the patient on a tilt table and putting that up to 70 degrees for 40 minutes with continuous ECG and blood pressure monitoring. There are three potential reactions you can see in vasovagal syndrome: a vasodepressor response, which is defined as a fall in systolic pressure of 50 millimeters or to below 80 millimeters mercury; a cardioinhibitory response, which would be a bradycardia to less than 40 or asystole; or a mixed response. You can identify that by inhibiting the cardioinhibitory response with atropine. So treatment for vasovagal symptoms, obviously avoid the triggers would be the most obvious one, but again, educating the patient about the problem is important. Again, maintaining hydration, and if they do feel that horrible lightheaded, nauseated, sweating feeling coming on, they can try again the same counter-pressure maneuvers for postural hypertension, and tell them to get their head down. If they can't lie down, get it between their knees. It's amazing how commonly well-meaning bystanders try and keep the patient sitting up and not letting them get flat, because that is what will resolve the symptoms quickly. The joint culprit medication, again, important. And I could have almost stopped there in terms of what is actually effective, because drugs generally don't help. There's several small trials looking at these drugs here, but really their benefit is limited, and again, adverse effects often prevent patients tolerating them. As a last resort, in people who have a drug-resistant cardioinhibitory response, you can put in a permanent pacing wire, but that's very rarely required. So trying to pull that all together, that's a number of, if you like, slightly disparate conditions. How can you try and pull this together in the patient before you? Well, the first question I was asked is, what was happening at the time? Were you standing up in a warm, crowded room? You know, for instance, the patient says, well, it only happens when I'm out at a party or something like that. It's very likely to be vasovagal. Was it on exertion? I'd be very concerned they had cardiac disease. Were there very specific things that brought it on, like prolonged coughing or straining to micturate or defecate? Probably a situational syncope. Did they just have a heavy meal? Postprandial. Postural change. I just stood up to answer the doorbell. Postural hypertension. The head movement, as I described for cervical OA. But then many people say I wasn't doing anything. I was just sitting at rest. And then I'd worry about the arrhythmia, or possibly whether they had anxiety, and this was related to hyperventilation. Associated symptoms. Are there any cardiac symptoms that would put a red light on the need for cardiac investigation? Or are they more the nausea and blurred vision sensation you get with neurally mediated syndromes? Look for possible exacerbating factors, as I've described. Always examine the heart for murmur and whether the pulse is irregular. And try and see if you can reproduce their symptoms with hyperventilation and neck movement. Investigations, I think everyone should have a 12-lead ECG, and everyone should have their postural blood pressure checked, because A, you don't want to miss a cardiac diagnosis, and B, postural hypertension is so incredibly common in older people. Otherwise, you have to be very selective and individualize your investigations. And I've just given a few examples here of when it would be justified to do more intensive investigation. Obviously, things like synaptin tests would be very rarely required, shouldn't be part of a routine workup. It's also worth, although this slide says cause of syncope by age, I could equally apply to pre-syncope. And although we always jump at the thought of dizziness being a result of cardiac disease, you can see in fact that actually it is relatively rare cause of dizziness, particularly in younger people. Cardiac and structural disease barely features it's all to do with orthostatic hypertension, a little bit of arrhythmia. And even in the middle-aged, it's still orthostatic hypertension and nearly mediated syncope that overwhelm the number of people that actually have cardiac structural disease or arrhythmia. But in older people, heart problems do get more common, so you have to have a much higher level of suspicion for those. Although again, yearly mediated syndromes are in fact ultimately the most common diagnosis. So that brings me on finally to unsteadiness, a favourite holiday snap of my dad. Not really. Anyway, unsteadiness can be the result of any problem that arises in the control of balance. So I've already spoken a bit about this in the talk on falls. But any problem with the sensory inputs from vision, proprioception of the vestibular system, any pathology affecting central processing in the brain or spinal cord, and anything affecting the function of the muscles and joints as the effector responses. Now that sounds like an overwhelmingly difficult and complicated assessment you're going to do, but my secret trick here is just to watch the patients walking, because different pathologies will cause very characteristic gaits and can allow you to immediately hone in on what the most likely diagnosis is and concentrate your further efforts in examination and investigation on that. So open your clinic door and get the patient to walk 15, 20 minutes, 20 metres up the corridor and back again. And hopefully by then you'll have a fairly shrewd idea what exactly is causing their balance problem. I'm not going to read all these out, but I'm sure everyone here would recognise an antalgic gait or stamping gait of sensory neuropathy, the shuffling and festulation of Parkinson's disease. As I say, you can then focus your MSK or neurological examination accordingly. So, as a geriatrician, unfortunately, things aren't always in these nice, neat 3 boxes. I often get referrals like this from family medicine practitioners. So thank you for seeing this 82-year-old man who complains of long-standing dizziness, which has recently become more severe. He feels unsteady most of the time, but there are episodes when he also feels lightheaded. This is so severe, he has to hold on to furniture to prevent himself from falling. He's got a lot of comorbidity there with his diabetes, hypertension, and osteoarthrosis. You can already see medications there that are making your antennae twitch as to which might be relevant. But it's quite clear there's more than one thing going on. His balance is a problem, but he's also lightheaded. Where do you start? Well, again, this is my attempt at a structured approach to this. First, the history. Can you fix which symptom domain the problem largely lies with, or if there's 2, which 2? What triggers are there? What associated symptoms does he have? Is he in fact blacking out, as well as just feeling dizziness? Is there problems with his hearing? And let's get the details of this medication. And right away you can pull out the people with syncope, who are going to need cardiovascular investigation, and the people with vertigo, hearing loss and tinnitus, that are going to need more of an opological or neurological approach. You can then focus your examination according to the symptom domain. So for those with vertigo, Hall-Pike test may immediately give you a diagnosis. For those who are lightheaded, depending on their triggers, you can then focus down on which specific examination to pursue. And if they're unsteady, have a look at their gait. And as I've just explained, that should then lead you into a specific neurological or MSK examination. Now, at the end of that, there will be a few people where you haven't been able to make a specific diagnosis, and you're going to have to go on to further investigation. However, in my experience, if you do a thorough history and examination like that, you will likely come to some conclusion as to the cause of their dizziness, which you can provide to the patient there and then in the clinic. Do not underestimate the value of reassurance as a management tool, particularly in people who are anxious. As I say, it's the beginning of their recovery. So what about treatment for these people with many different causes? Well, obviously, if you find a specific disorder, go ahead and treat it. But often you find, particularly in very frail older people, that's not enough. They still feel unsteady and a bit lightheaded. And it's well worth, at that point, pulling back on their drugs, particularly the antihypertensives, and also trying physiotherapy for balance and strength training, which will often also improve their confidence and reduce the associated anxiety that I've described. So, to summarise, not describe many rare and exotic causes of dizziness that are out there, but the reality is they are rare and exotic, that you don't see much of them. And your patients are much better served if you have a good working knowledge and a structured approach to the common causes of dizziness. Thank you very much.
Thank you.